Hello, and welcome to MDGBoston's first online forum. Tonight, we'll be seeing a great forum on advances in minimally invasive surgery. My name is Jeff Karg, and I'm your co-chair for this evening. But first, before we get going, I'd like to give thanks to Bill Dennison and Bill Munger, our operations team, that have made this webinar, this forum, this virtual forum possible. I've been involved in MDG since 2012 when I attended my first software integration group. It was a great meeting and I very quickly joined up and became a member of Program Central. Over the next few slides, I'm going to show you that I'll be showing you a little bit about what MDG is. We'll hope that you'll become involved with our organization. If you do want to reach out for any questions that you might have about the forum or about MDG, please feel free to contact me at jeffreykarg@gmail.com or on my cell phone below. MDG has been a professional volunteer organization since 2001. We have about 330 active members in the organization now and over 7,000 newsletter members. Members benefit from the expert forums that we present 10 times a year through collaboration and networking with our large group of members. And everybody gains from the knowledge sharing that occurs from all of our gatherings. Overall, our mission is to advance innovation and technology for better healthcare for people. There are many benefits to being a part of MDGBoston, not the least of which is education through the forums, as you'll be seeing tonight. But members also gain access to a deep and mature contact database, and there's a lot of cross-membership mentoring, as there's folks from every part of the technical and MedTech environment that are available for contacting. MDG also has the opportunity to get involved with our organization in activities and committees, as I am. And then also we just really enjoy that there's a growing communal awareness of the complex MedTech space through our activities. There are 2 more forums coming up in the next few weeks. The first one is this Thursday, May 14th, 2020, the rise of open source and do-it-yourself medical devices. And then there's one on June 1st, human-centered medical device design for global health. Probably a very apropos topic for what we're going through globally right now. Tonight's forum was provided complimentary by MDGBoston. Future forums will be carried on at a $15 membership fee and a $25 non-membership fee to cover the costs of our nonprofit organization in presenting these forums and other expenses. So without further ado, we hope that you'll join us for future events. But tonight, I'd like to present BRYCE KLONZ. I've gotten to know Bryce quite well over the past few years. He's currently CEO of NewView Surgical, an exciting and early stage company in the MedTech space that is well on its way to developing a new platform for surgical visualization and access. Previously, Bryce spent several years at US Surgical Covidien, where he led teams developing and launching new technologies for minimally invasive surgery in the United States and in Europe, while also spending 3 years heading up surgical devices business for Covidien in Asia out of Singapore. Bryce also brings with him an extensive early stage MedTech experience, having worked at startups in both the cardiac and orthopedic spaces throughout his career. Bryce will be moderating our 3 speakers, Tom CALEF, ILSA WEBECK, and SAJANI SHAH. ILSA WEBECK, by the way, is also a board member with MDG, and we hope you'll get a chance to meet with her in the future. Thank you very much. Bryce, the floor is yours.
Hey, Jeff. Hey, thank you. And thanks, everyone, for joining tonight. Thanks to MDG for hosting this event. I know that you guys are used to your in-person forums, which I've attended on many times and are excellent. But hopefully the push to online webinars under the circumstances will certainly open up some opportunities to expand the network and expand beyond New England, as Peter suggested before. So our topic this evening is near and dear to me. Most of my career has been spent in the MIS space, and I think we've put together a great panel of folks tonight to talk about the many issues that we have. A lot of exciting technologies in MIS, of course, robotics and AI and VR, and a lot of other technologies that are out there. But this is also a balanced spine environment, which is experiencing cost pressures, the need to increase efficiency, the need to increase and improve the experience for patients and providers as well. So a lot of interesting topics to cover, and we've assembled a great panel. So just in brief, and I'm going to provide some more in-depth introductions as each presenter readies their talk. But in general tonight, we've got Dr. Sunny Shah from Tufts, who's going to talk about her experience as an MIS surgeon in adopting new technologies, in the unmet needs that she still sees that needs to be addressed. We then have Tom CALEF, who will be talking about robotics and AI, and ILSA WEBECK will be presenting on ortho spine and some really interesting technologies there. And then I'll wrap things up with a presentation on consumer technology and how that's changing the landscape of MIS as well. So just a quick note, if you do have questions for the presenters, you can write those questions into the Q&A function at the bottom of the screen. We will not be doing a Q&A in between presenters, but we'll be addressing questions, as many questions as we can, as we wrap up the session once all the presenters are done. So with that, let's go ahead and turn it over to Dr. Shah. As she pulls up her slides, let me do an introduction for her. Dr. Shah is an assistant professor of surgery at Tufts University School of Medicine. She's the chief of MIS and bariatric surgery at Tufts, as well as its director of surgical quality and safety. She's well published in several books and journals on the topic of minimally invasive surgery and has been involved in surgical research, acting as the PI in multiple studies. Importantly, she's a very active MIS surgeon with experience adopting and utilizing a wide array of surgical tools, from basic instrumentation to the most advanced robotic systems. So a lot of really practical experience for us to leverage here tonight. She's put together a fantastic talk on the technical future of surgery. Dr. Shah, over to you.
Thank you, Bryce, for that great introduction, and thank you, MDG, for inviting me tonight to talk about a surgeon's view and perspective on the advancements in minimally invasive surgery and where we're headed. To start the conversation and to sort of give you some introspection to what surgeons want and the value that we're trying to create. When a patient comes to us for a certain problem, whether it's cancer surgery or they want their hernia fixed or they need their knee fixed, the number one thing that's really important to us is to make sure that we successfully treat their disease or their problem. And what that goes along with is making sure we try to reduce the complications for patients, such as bleeding, having to reoperate, or the fact that we didn't take care of the cancer in its entirety. Patients' experiences, such as how long they're out of work, how much pain they have, even things such as the incisions that they have on the outside, because sometimes patients don't really understand the work that's been done on the inside and they only can see what's been on the outside. And really I'm talking about, when you look at this equation, is the numerator, and there's things on the denominator such as cost, right? So direct cost, meaning the technology, the device, the platform that we're using to either do the procedure, and then the indirect costs such as the time it takes to do the procedure, the resources that are needed to do it as well. And sometimes the denominator or the numerator actually drives the denominator, but truthfully, all are important. But the number one thing is making sure that we do the right thing for the patient and that we take care of the problem that they've come for. So when we think about the evolution of surgery, and when I think about it as a surgeon and when I talk to my colleagues, we think about how we've gone from open surgery to laparoscopic surgery to robotic and the future. And we think about laparoscopic surgery in the 1980s, a huge leap in terms of technology, right? So really we think about access and how we're getting into the cavity to do surgery. And that means faster recovery, faster return to work, decreasing length of stay. And there's been some data to definitely prove that the outcomes have improved as well. Moving forward to robotic surgery, really the access hasn't changed as much, but now we're actually looking at the pain points of laparoscopic surgery, such as the fact that we lose the 7 degrees of freedom, the fact that sometimes we're not able to see as well, and robotic surgery has definitely push the envelope when we think about the pain points of laparoscopic surgery, and then looking forward to where Surgery 4.0 will lead us. All right, so open surgery. So, you know, the question that I always ask and my colleagues ask each other is, why is open surgery still exist? Well, there's one big advantage of open surgery, and that it's proven, right? Sometimes there's disease processes or treatments that need to occur that are just too complex. And with all the advancements in technology, we still are not able to do this laparoscopic or robotically. Disadvantages to open surgery, definitely the fact that you have to make a big incision. This impacts the patient's experience. This impacts how long they're in the hospital, and even impacts sometimes outcomes. And really the opportunity of where open surgery can go will be really thinking about how we can use existing technology, and in the future, how do we use technology to convert open surgery and give them the tools necessary for them to be able to do it with minimally invasive approaches. So then thinking about Surgery 2.0, laparoscopic surgery, which is really near and dear to my heart because I am an advanced laparoscopic surgeon. And so the advantages, I could have filled the entire slide with the advantages, but I think the big one is we've been doing it now for over 40 years and it's proven. For those that have adopted it, the skill set might be, might be a steep learning curve, but it's all worth it because patients have better outcomes. We know that because we have 40 years of data to prove it. I believe the vision of laparoscopic surgery is definitely better than open surgery, and a true laparoscopic surgeon never wants to open because we really believe that if we have to open, it's because we run into trouble. Usually it's bleeding or something that we just can't figure the anatomy out laparoscopically, and having to open it just makes it that much more harder. Disadvantages, if you're an open surgeon and you haven't really adopted laparoscopic surgery, it might be because you do lose some of the haptics that you have with open surgery and the 7 degrees of articulation as well. Opportunities. I mean, there's still many opportunities. It baffles me that in 2020, when all the technologies are becoming smaller and smaller, that I still walk into my laparoscopic OR dedicated room and I see equipment, wires, towers, screens that I still cannot figure out why they don't go where I need them to. There's definitely room for that in the laparoscopic world. So to fast forward to robotic surgery, which is definitely a very exciting time for laparoscopic surgeons, and maybe even more for open surgery. So I've adopted some robotic surgery in my practice, and in doing so, I realized that really the benefit for robotic surgery, because when you think about it, when you compare laparoscopic surgery to robotic surgery, really it's still small incisions, but where the benefit lies is that it really mimics open surgery. And what do I mean by that is that when you think about the fact that you get the articulation that you would have in open surgery, meaning the 7 degrees of freedom, when you think about the view that you might have when you're doing open surgery and you compare that to robotic surgery, you really have that same top-down approach. And then thirdly, when you think about just the eye-hand coordination that you have when you do open surgery, it really mimics robotic surgery really well. And so I think robotic surgery has definitely helped those surgeons that felt more comfortable open for a variety of reasons to make it better for them to just incorporate new technology and make them feel comfortable. But really, when I think about robotic surgery, I think of it as a stepping stone. I see it as a stepping stone to really taking us and leaping us into Surgery 4.0. I see robotic surgery becoming a centralized platform because it has the capacity to take all the data points, whether it's computer learning, whether it's AI, virtual or augmented reality, and being able to take all the different data points, even from past experiences, right? So thinking about all the data that's been published and to say, take all that information to help surgeons make better decisions. So what are the challenges that surgeons have? So the challenges are, you know, it's really hard. Like, we don't want to just jump on the newest procedure or the newest technology or the newest device, right? We want to make sure that this device or this procedure or this platform makes sense for this particular patient or this disease process. But nor do we want to lag behind, you know, the innovations and the benefit that we can bring to our patients. So there's a balance. There's a balance of looking at everything that's around us and what makes sense that we should incorporate and what we shouldn't. And sometimes we don't even know what we need until we see it, right? And then when you look at this graph on the right, it really reminds me of like where we have been and where we're trying to go. And if you look at how we've jumped from open to laparoscopic to robotic, it makes sense to me, right? So we're taking the approach of how do we decrease the trauma to the patient with less scars, and how do we increase the experience for the surgeon to do what they need to do best. But all these things still require the skill set of the surgeon, right? It doesn't take away the fact that there's so much variation in surgery. And how do we, with all the data that we have, help surgeons make a better decision and do a better job when they're doing procedures? So that takes me to my next slide and talking about the balance between humans and robots. And I think this is really an important thing to think about. And what can humans bring to this and what do robots bring to this, right? So humans are good at quickly processing extensive and diverse qualitative information, right? So we've taken what we learn from the patient, what they want, we look at their scans, we have, you know, years of past experience to build on. And now we're thinking, how do we treat this patient? Robots are great at taking all the diverse information they have, but it's more quantitative, right? So they can actually tell you exactly the diameter of this vessel, and even taking it a step forward, not even telling us the diameter of the vessel, but you know what, this thing is pretty big. You might want to use this ligature to take control of this vessel, right? So how do we marry these two to really propel where surgery needs to be? You know, surgeons we're type A, you know, we like to be the captain of the ship. We don't want the robots to doing the entire procedure. I don't think you can find one surgeon to say, yeah, I'm going to sit back and let this robot take out the spleen or take out the gallbladder. That's not what we're looking to do, right? We want robots to help us. We still want to be the captain of the ship. So when I think about Surgery 4.0, you know, the way I look at it, we got to use all these technologies, you know, again, talking about computer learning, talking about machine learning, all the big data points, all the imaging, all the virtual and augmented reality, and trying to get all the technologies all into one place, right? So how I envision it is even thinking about, say I'm going to do a laparoscopic kidney removal. Right now, when I make incisions, whether it's robotic or laparoscopic, I'm just using external markers. Like maybe I should make the incision here. And a lot of surgeons will tell you, you can make or break the surgery from the beginning. You put your incisions in the wrong spot, you just added about 30 minutes to your procedure, and forget about the frustration of getting through the procedure, right? But wouldn't it be great that this new, you know, Surgery 4.0 with this new fascinating, beautiful operating room, it actually can tell you, you know, based on what you want to do and based on the internal, you know, anatomy that I see, perhaps you want to make the incisions here, here, and here. And that would be really helpful, right? And just thinking on the flip side, if I'm about to close this person and if I happen to open the patient and have to make a big incision, it'd be great to say, you might want to place your sutures here. And then taking it even a step further, if there's a complex procedure such as a Whipple, which is taking out pancreatic cancer, which requires multiple anastomoses, some are very tiny and small to see, and really sometimes a pain point for the cancer surgeon, wouldn't it be great to say, tell the robot, okay, I want to take this pancreatic duct and I want to attach it or anastomose this to the pancreas. And the robot's able to look at these two structures, determine based on the thickness of the tissue, the length and the caliber, what type of suture it wants to use, how far the sutures need to be, and actually perform the anastomosis. Really, this is where I see surgery going, right? How do we help the surgeon with complex procedures that really requires more of a quantitative approach than qualitative? And how do we decrease variation between surgeons, whether it's nationally or globally? So in conclusion, where do I see the future of MIS? Whatever technology, whether it's, again, virtual reality platforms, getting the robot to be more autonomous, whether we use big data from all the data sets that we have in the literature, or we're able to use images and superimpose. The biggest impact that we can make is really how do we decrease variation in surgery. So it's thinking about if we have 300 surgeons doing the same procedure, how do we enable the surgeons to try to conform to how exactly they do the surgery with technique and technologic abilities. Thank you.
Thanks, Dr. Shah. Appreciate it. Great insight, I think, from a group here that's largely focused on development of medical technologies. It's so critically important to understand the user needs, understand your perspectives, and understand how that technology is going to impact exactly what you do every day. So I really appreciate that presentation and the insight that you provided. Again, as a reminder, if you have questions for Dr. Shah, please go to the Q&A icon at the bottom of the Zoom screen and post those, and we will do our best to circle back and address those once we're done with the presentations today. So with that, and I think it was a great lead-in to our next presenter, Tom CALEF.
And Dr. Shah,
surgical robotic systems through 510K clearance and onto market release while at RTS Life Sciences, as well as Robotics. Tom is currently the Chief Technology Officer at Activ Surgical here in Boston, where they're working on a really fascinating visualization system for MIS, on top of several other projects that clearly fall under the future of surgery umbrella. So with that, Tom, over to you for a talk on robotics and AI. Thanks.
Great. Thanks a lot. Thanks a lot, Bryce. And Dr. Shah, I think we're going to find that, a lot of we have a lot of parallels here in the presentation. And we're going to start off right from robotic surgery innovation. And, the way I look at it is in innovation, and especially with robotics, it's really when and how can we augment the surgical intelligence, and it's to deliver the right care at the right time. And this is really an exciting time in the space. The slide here shows Roger Smith's robot of the day on LinkedIn, which is always compelling to me. Shows that there's 77 companies in the surgical robotics space. This is growing by the month. We'll see new companies come out of academia and start to commercialize. But really, it's also been fairly active on the acquisition front, right? So we just saw Intuitive Surgical acquired Orpheus Medical, which is a video recording device and an ability to aggregate data. Also, Medtronic has released a AI device in GI, and has also acquired Digital Surgery, which is a surgical training platform. So really, really exciting time for us to move forward. But as we kind of look toward innovation, really where the industry has been innovating with robotic surgery is on 3 tiers, right? It's access, it's visualization, and it's instrumentation. And the ability for us to access something in a new way, then visualize it and provide instruments, it's this circular, it's really this virtuous circle where as soon as one is improved, then you need to improve the other 2. And it just keeps going around and around. But really, where I think that we need, why we need to innovate is, even with all this technology that's come out, all of the procedures today still rely on human experience. This is the study out of the New England Journal of Medicine, and it shows here that there, just pretty much what we all expect is surgeons that do more cases actually have a better chance of performing well and performing less complications. So what's shown here down in the number of patients in the fourth quartile is that the surgeons are doing more. So 4,300 cases for 5 surgeons compared to 4,500 cases for 10 surgeons, actually have scored significantly higher on their peers' ability to perform the procedure. Now, what's also interesting is it's not linked to the number of years that the surgeon was actually in the OR. So as you can see here in the first quartile is actually the mean surgeon length as a bariatric in practice is 11 years, same as quartile 4. So it's not really how long they've been in practice, but more how many procedures they've done, which, I mean, to all of us in the audience, it just makes sense. The more you do something, the better you're going to get. That being said, medical errors are accountable for over 250,000 deaths every year, right? So it's the 3rd leading cause of death in the world. The first 2 vary between the world and the US. In the US, it's heart disease and cancer, then medical errors. And this is, quite honestly, is something that we just don't talk much about. As it stands today, as I checked yesterday, the pandemic of COVID, we're right around 50,000. So you can kind of tell the kind of magnitude as to which we should really address this. So how does technology help? Again, looking to the press most recently, and COVID-19, in December, an AI company named Blue Dot, they use web spiders and other collections of information to aggregate data from around the world. Actually, they announced a unusual cluster, or a cluster of unusual pneumonia to their client space and to their governments. And they could actually pinpoint it right to Wuhan, China. Now, this is really interesting to me. Honestly, this just came up on my feed a couple days ago, but I think it's really important because it's how we look at artificial intelligence. Their CEO said it really well. We don't use artificial intelligence to replace human intelligence. We basically use it to find needles in the haystack and present them to our team. It's what computers are really good at. They're really good at analyzing really quickly, small amounts of data, and pick out the smallest trends that maybe to a human we don't see. So it's how do we take that and move it forward to advance surgery. In particular, what I'll go into here is robotic surgery. So I'd like to present something to the attendees, which is how do we look at surgery? How do we redefine it? We've been talking a lot in the industry about digital surgery. So how do we go from digital to collaborative? And there's a number of stages that I believe that as an industry we'll go through. Stage 0, singular surgery. Every surgeon and every surgery sits by itself. We don't go from one to the next. Stage 2, surgical enhancement, where the surgical experience is augmented through small feature sets, whether it's tremor reduction, whether it's better cameras. Stage 2, surgical assistance. So the surgeon plays the active role in driving all surgical decisions, and then uses small feature sets to augment the surgical assessment. And we'll get into that a little bit later. Stage 3, and honestly to me as a roboticist, this is really where it starts getting exciting, is surgical guidance. So even though the surgeon's actively engaged, the system can trigger predefined functionality based in the surgical landscape. And we're seeing promise of this today, and we'll get into that a little bit. Stage 4 and stage 5 is really as we start working toward collaborative surgery. Now, I'm not talking autonomous surgery, and I very much agree with Dr. Shah. We're not looking to replace a surgeon. What we're looking to do in the end goal is to make the surgical systems just as aware and really understand surgery so that they can be capable to perform pieces of the procedure, and that the system and the human can pass back and forth control of the procedure in any case, but really at the right time. So maybe sometimes the surgeon is better at opening or dissecting, but maybe the machine is better at suturing. Sewing machines have been around for a long time, and they're really quite good. So why don't we have a machine suture up a patient? So where we are today is stage 2. And why do I see it that way? So what we're seeing in healthcare today, we have dermatologists, you know, they're using AI for skin cancer detection. And actually the detection is outperforming the dermatologist, and same in breast cancer. Google DeepMind released some really impressive data that the AI actually outperforms the doctors in that case. And you know, we can go into this over and over again into how the data is presented. But that being said, it's really promising. The tools are showing huge value today, and we're only going to build upon that. But really, again, how do we get to stage 3? That's the next thing. How do we cross that chasm from stage 2 to stage 3? And we're seeing this a little bit. Something that honestly is near and dear to my heart, and you know, we're very proud of at Activ Surgical, is the follow-on work that's being done at University of Maryland using the STAR platform, and continuing to show the promise of autonomous robots and autonomous systems in very precise surgical tasks like cauterizing or dissecting or more suturing. But we're also seeing other work done. So the University of Washington has their Raven 2 system. This has not only been seen in movies, but they're actually doing really incredible autonomous surgical work using this platform. And then in the bottom right is out of Stanford, this is their system. And you know, again, I think Goldberg is behind the system and really doing a fair amount of you know, surgical dissections and knot tying and that kind of thing, all autonomous. And you can imagine sometimes it's hard tying shoes, and you know, we can take a robot and now tie surgical knots. So quite impressive. But why is it taking so long to get there, right? And honestly, teaching a robot how to do surgery is hard. A lot of really good work going on. Primarily, I'm biased locally. A group over at MIT and Harvard and Mass General, they're doing some incredible work using supervised and unsupervised learning to push forward and detect the phases of surgery. So Dr. Morellis, Dr. Hashimoto, Daniela Roos, like, you know, doing just incredible work here. And what they've shown is that with 78 data sets, they've been able to train a system such that they can look at a gastrectomy and break it down into surgical phases. And so you can see here, case A and case B, what those, you know, in a great procedure is case A, where each step is one after the other, very sequential in nature. And what happens there, just as Dr. Shah was saying, we can then quantify. We can quantify how long do you stay in a certain step? When does the surgeon move to the next step? And these are all things that we can now take and push robotics and really show robots how to perform the procedure. What's really compelling is case B. Case B is where there's surgical complications. You see that we actually miss that stair step, right? And this is where we're going back and forth between the different steps of the procedure. This can be used today to say, well, maybe this patient is at a higher risk of post-surgical complications. And really, you know, because that training is so hard, how do we augment it? How do we make it better, right? And some of the work that we've done at Activ is we've used crowdsourced labor to annotate images. And you can see here on the left-hand side, our annotation efficiency from week 1, when we were just training the annotators, it took over 10 minutes to annotate a single frame of a 60 frame per second video. It takes a long time. We've got that down now to just under 4 minutes, but still a long time. So how do we improve that even further? We look at it as we can now bring quantification into the operating room, right? So as you can see here, this is Activ Site Gen 1.0 product where we can quantify blood flow. Now, why is that important? Well, it's important. There's a clinical need. We want to know where blood flow is when we go to cut, and that's really important. But really, in terms of how it's important for artificial intelligence and machine learning, is we can now threshold using standard image processing techniques and call out those vessels. We can also, on the bottom, now we start taking into the spatial characteristics of surgery, and we can overlay that data in very precise locations in the surgical field. So we can quantify, in sub-millimeter accuracy where things are in the field. And now we can tell a robot to go somewhere and tell a robot to do, the next great thing. Once we actually learn how to do a task, now it's help perform it. This is what we did in December of 2018. We have a live animal study and 2 off-the-shelf robots. And we actually closed a ventral hernia, with no hands, right? Hit a couple of buttons and the robot went and sutured the peritoneum closed. We won't have this video go all the way through, but this is the same robot working on a phantom. And as you can see, there's markers placed, and this is all through an algorithm. So there is no human touch in this whatsoever, using an off-the-shelf needle passer, and can go through and would actually suture up, this whole thing. We'll kind of skip that along just for the sake of time. So you can imagine how we can actually work through in suturing. So now the question is, with all of that said and done, so we can teach robots to do amazing things. Now, would you let a robot perform your surgery by itself? So our founder, Dr. Pierre Kim at Children's National Medical Center, presented in 2016 that the robot was actually better in terms of repeatability. It was highly accurate in suturing and outperformed surgeons in a number of cases in a very complex task. So how do we get there, right? It's not only a technological leap, but there's also a psychology leap. So how do we get there? When am I going to sit on the table and say, okay, a robot can do it? Now, small polls that are done from PwC, 54% of people are willing for AI and robotics to actually intervene with their healthcare. We have a long way to go here, and it's gaining trust of the patients and really pushing that forward and doing it right. So how do we make it better? Learning from big data. There's a lot of great things that we can garner from the tech, the tech titans that are out there today. BRYCE will jump into how we work with some of the consumer electronics that are available today. But things that just make sense. Utilize known architectures, Internet of Things, incredible architecture that we can follow, placing devices at the edge, cloud connectivity, bringing the data up and learning and deploying things. We have to provide access to medical professionals to annotate. Small data sets in surgery is one of the big areas of concern in terms of getting AI and empowering machine learning. Is really we just have small data sets, maybe 200, 300, 400 cases when we're going to need tens of thousands. How do we do that? And really annotating that to obtain that ground truth data is really important. We have to remove all the friction for a surgeon to want to go in and annotate, or maybe they do QA on the data. It's all really, all of these steps are really important for us to nail. And then finally, devices that are open and can be integrated together. We have to be able to integrate with EHRs and vision systems and patient data, advanced surgical systems like robots. All of these things, we need to stop looking at devices as closed entities, start having interfaces and interoperability moving forward. So wanted to talk real quick about how we're looking at AI at Activ Surgical. And we're starting from the source. We're starting from collecting the data, putting it through neural nets, and then providing intelligent outputs and what we call clinical insights to the surgeons to really move forward and help them make the best decision at the right time. So we've developed a very straightforward imaging module that connects to every surgical laparoscope and surgical camera for us to start collecting that, what we call intelligent data or a correlated data set, for us to move forward and provide that quantified information that we can learn off of and present that to a surgeon in the operating room to show where blood flow is, and this is with no dyes or anything like that. It's just we can quantify blood flow in real time and provide that for the surgeon immediately. But it feeds into the bigger play, which is our Activ Edge platform. We're able to pull in 2D video, fluorescence, hyperspectral, ultrasound, MRI, CT. We pull that together. We have annotation tools and annotators set up to work with it, and then deliver it to the point of care for that real-time inferencing at the edge. So there's a lot to talk through here. You can run through or always ask questions on how we look at AI and the things that are there to empower it. But really what we want to get to is the inferencing at the edge that gets something like this. This is achieving the critical view of safety in a lap chole and being able to identify structures that we can stay away from, make sure that the surgeons don't hit, and really push surgery forward and make sure that we give surgeons all the data that they can use today. So I know it's a lot, but thank you very much for your time. If you have any questions, the QA's open. Thanks a lot.
Hey, thanks, Tom. Appreciate it. Great presentation. Fantastic. It really speaks to the exciting technology that's ahead, but also the difficulty in getting there.
Thanks.
Big data, all the experience from multiple surgeons, particularly with that the variability across surgeries and surgeons, but really exciting stuff. So thanks. And again, if you guys have questions for Tom, I see a good list of questions coming up with the presenters. As Tom said, please put those in Q&A, and we'll do our best to work through those moving forward. So our next speaker, get up ILSA WEBECK. ILSA is currently the Managing Director at the MedTech Strategies, where she works with companies on new technology initiatives with a focus on identifying value and pathways for growth, helping those companies clarify how innovative technologies fit into our complex healthcare marketplace. Certainly top of mind for our audience here this evening. She spent several years at Johnson & Johnson in DePuy Spine, the technologies of which she'll talk about tonight in the ortho spine space, as well as spending time at Biogen IDEC, as well as Health Advances. She's a lecturer at Boston Biomedical Research Center and a member of the board of directors of our esteemed host tonight, MDG. With a look at advances in technologies in orthopedics, ILSA WEBECK. ILSA, over to you.
Thank you, Bryce. Thank you very much for the opportunity to speak this evening. I think it's been a really great overview so far, being able to hear from a surgeon's perspective and also hear about the advances in soft tissue procedures. What I'll do is take a case example approach with a focus on MIS in orthopedics and spending some time specifically speaking on spine, and as well how robotics have integrated into these areas and some of the outcomes and the costs associated with these procedures. So to jump in, for those of you that don't have a lot of experience in orthopedics, I thought I'd just give you an overview of what this looks like. So in particular, there are surgical goals that the orthopedic surgeon is really trying to accomplish, both in the total joints and spine area, which I'm going to focus on this evening. First, looking to decompress the joint to reduce pain and eliminate the issues with what's going on in the joint space itself. Looking to stabilize the joint at that point, either through replacing the joint or putting in a fixation for spinal element, which will reduce movement. And lastly, really looking to reduce any deformity and return the joint to near normal positioning for function. And surgeons have really been doing this successfully for decades, as we all know, through the open techniques. But with MIS, the advent of MIS and the development of more techniques to use minimally invasive surgery, really looking at how this procedure can improve and move things forward. Someone said that my slides are not being shown, so let me pause for a moment. Sorry about that. Bryce, let me know if, can we see it now, Bryce? Okay, sorry guys. First tech glitch of the evening. So here, this is where I was talking through the open and MIS procedures in for spine, hip, and knee procedures. So for orthopedic surgery, you know, it's really a complicated set of maneuvers, as many other surgeries are. So imagine you're trying to build a ship in a bottle, though, where you have a lot to do inside of a small space. And really trying to get everything to fit through that small opening, make sure everything fits together and is working properly. The only challenge is that the you know, the bottle isn't clear and you can't see what you're doing. So in orthopedics, you know, you have that added level. Well, you know, in MIS procedures, you have that added level of complexity. And with the advent of robotics, it would be nice if there was this cute little robot there to help us make this all work. But in real life, you know, things are much more complicated. So to achieve goals for MIS, you know, contrary to soft tissue surgery in orthopedics, it frequently requires not only removing and manipulating soft tissue, but also bony tissue, or removing those as well. And then inserting, you know, a fairly large device into the space where those tissues were removed. Fairly robust set of instruments and equipment used to either prep the space or insert the device, and then assemble those devices in space. And since we're going to take a deeper look at spinal procedures for the rest of the talk, if you're not familiar with spinal fusion procedures, you know, this is here with screws and rods, interbody fusion devices being put in posteriorly through the spinal elements to lock the segment in place. So that's the procedures that I'm generally going to be talking about for the rest of the evening. The key here is there are you know, very sensitive structures here. There's obviously the spinal cord or cauda-equina, depending on what your level you're at, and any ascending and descending nerve roots that you want to avoid while you're putting sharp and pokey devices through to fixate the segment. Well, all those illustrations and sawbone models are really nice representations of what it all looks like. You know, live in real life MIS surgery and orthopedics really is a complicated tangle of instruments, devices, tubes, monitoring equipment, and with that extreme focus on one or more small openings by, you know, the whole slew of surgical and medical staff that's in the room at one time. That being said, though, you know, there are benefits seen through using MIS, and those benefits have been shown to outweigh the drawbacks. Significantly morbid procedures such as for adolescent idiopathic scoliosis, so for AIS, you know, surgeons are essentially placing an internal brace inside these patients. You can see that there's some more obvious benefits. You know, the smaller incisions, smaller scar for patients. A lot of times it's a you know, teenage girl that doesn't want a huge scar down her back. You can see there would be a decrease in blood loss, and, you know, some other obvious benefits through using these procedures. And for this deformity procedure or a similar procedure like a 1 or 2 level transforaminal interbody fusion, or a TLIF, researchers have found that these benefits are there and roughly similar. You know, they've seen that they have the opportunity to have benefits from using MIS in these procedures. In looking at the efficacy and safety, however, you know, there's still some question about whether or not the efficacy and the safety associated with either of these two procedures for spinal surgery is any better, or if it's similar. And so for each patient, the drawbacks or the increased OR time and the needs to operate and go up the learning curve must be balanced with what could be seen as roughly equal clinical results. And so, you know, if it looks good on X-ray and if the scar looks good, you know, is that enough? And are you really achieving your goals? And so the question that, you know, we want to address today is, what else can we do to make improvements for these patients? So in order to do that, I want to just take a quick look back. You know, the modern approach to MIS and spine was developed in the mid 80s, about the same time the first brain biopsy robot was developed. But then it took about another 20 years for percutaneous screw systems to be launched and available. And then soon after that, the Mazor Spine Assist was available on the market. And you can see how the intuitive devices or robots are hitting in here as well. And then for the Mazor system, it really wasn't until around 2011 when they launched the Renaissance tool, where it became more visible in the industry and people were more aware of its presence and interested in using it in their procedures. And that was their second generation that launched. And so now we're almost 10 years past that, and the Mazor X Stealth Edition, which is a new Medtronic version, which I'll show you in a moment, is out. And then, the other companies are now as well hitting the market with robotics for spinal procedures. So, if you think back to that ship in the bottle example, and asking, what are these tech options? What are they doing? What can computer and robotic assisted devices or technologies do in spine surgery? What can really be done to kind of make that bottle disappear and make things easier for the surgeon? So there's several nice to haves to make things better instruments, better accuracy. Obviously better outcomes is key to moving this forward. But also, looking at the impact of these new tech devices on the whole procedure itself is kind of an interesting deep dive here. Kind of what we heard earlier today is, you could focus on suturing, after the incision, after the procedure is done, there's a focus area for robotics. And for robotics in spine, a lot of the focus has really been on prepping the pedicle, which is a part of the bony anatomy of the vertebral element, for a pedicle screw. And the whole rest of the procedure is still done by the surgeon, and the robot comes in for one particular area. And so that being said, what's the impact on all the next steps? These tools have been built to assist the surgeon, but not yet to replace their hands. And so what are some of the tools that are now available and in place that are able to do that? First, I'll show computer-assisted navigation or image guidance. And this is similar to a GPS system in the OR. So the image guidance tools, they provide continuous surgical data, and it's displayed on the monitor in the OR. And these are fiducial markers, which help the system, the sensors on the system, to notice the location of the tools, and therefore lay the tool or instrument on the screen so the surgeons can know the location and where they are for what spinal element they're at and where that instrument is located in. This helps them for placing their screws, to know the screw trajectory that they are looking to work through. And there are many companies developing tools for intraoperative use. There's a few that are listed here. They are being used pretty regularly today to advance visualization and to either and use for implanting screws on a pretty regular basis. And how helpful would you say the image guidance is? The consensus is yes, it is helpful. We've seen an increase in accuracy in pedicle screw placement. It allows more minimally invasive applications. And they've also seen a decrease in radiation exposure to the operator. There's three key things to highlight. But is this enough just to be able to see the instruments better? And how do robotics fit into all of this? So as I mentioned, robotics in the spine is still relatively new, but there is a group of new tools and software and new instruments being launched every year. And one of the common things is across this set of instruments or those robotic devices is that they're really to be used with the surgeon and not in place of the surgeon. To Sunny's point about, the surgeon is still a surgeon. They want to be involved, or they want to be connected to the surgery and do what they're trained and expert at doing. And that's been the case so far in the tools and the robotics that have been developed for spine and some other orthopedic applications. And in spine surgery, the term "in my hands" is pretty common. So the surgeons like to have and like to manipulate, in their hands, certain devices and tools work certain ways, and some work better than others. So, in particular, I wanted to dig down into this device that's now partnered with Medtronic, the Mazor X Stealth System. This robotic system originally started as a set of actuators that you would put over the top of the spine in surgery. And the device would allow the surgeon to pick the trajectory through which they wanted to place their tools. And so, this device, as it evolved over time, essentially now is a robotic arm, which for spine applications, they are claiming that 7 degrees of freedom here. And but the device is being used the same way. It's allowing the surgeon to place a device through the robotic arm and to prep the pedicle for screw placement. And I have a little a video here that hopefully will work, that'll allow you to see how the system works in real life. So the surgeon can turn the imaging and adjust the location of the screw placement through the system, through the robotic system. And as that screw placement is adjusted and placed to where the surgeon likes it, then the robot says, okay, this is this location for this screw, and it will adjust itself to that location so that the pedicle prep instruments can be put in place. And then once the pedicle prep is, pedicles are prepped, as that little notice that was down here, it said that the screws must be placed without the robotic arm. So the pedicle, I believe it's because of the indications, you're only allowed to use it for the pedicle prep. And so this is an interesting way. It's another arm for the surgeons to have available to them to ensure that accurate trajectory, which is so important in spine surgery. So, with those tech tools available, how are they faring in the real world? And generally speaking, surgeons are seeing either comparable or better outcomes with several clinical factors, and that's really good news. We want to know that they're working, that they're out there for good reasons and they're working. And knowing that these tools are really benefiting patients and clinicians is coming through those reduced radiation exposure, through blood loss, length of stay, improved clinical outcomes is tremendous. So, seeing the robotics and the computer assisted or image guidance tools on the comparable and better side of the equation is what we really want. And literature demonstrates that there's an increase in screw accuracy after a quite significant learning curve. So this study showed after 150 learning screws, they were able to increase from 82% to 93% accuracy on screw placement. A case series of 9 different studies demonstrated an increase in accuracy from 93% from what their rates were before using the robotics and 95% after. So a little bit of an increase. And then compared to freehand surgery, the research has showed the improvements in placement, perforation rates, and then the OR time and fusion rates are really something that spine surgeons look at quite a bit. So that's good to see as well. No change in the reduction in malposition, infection rates, or length of stay in the study that's out there. And then amount of radiation exposure has been variable. Now, looking at this, nothing really jumps out to say that robotics is really the best way to do surgery going forward. There are still questions, from, myself and surgeons about using robotics in spine. And, the verdict is really still out. So a lot of those early issues that have come along with using robotics in the OR have been generally addressed, and the benefits are gathering support. But the challenge is that, the robotics is so new that there's a dearth in literature to guide surgeons on the right path, the right tools to be used. And we don't really know if that literature is missing because they haven't been able to prove these benefits yet, and so they're waiting to publish on the data that demonstrate those benefits. Or is it less accurate so far, and they haven't been able to overcome the sort of the good enough the level or not? Given the high costs of using robotics, wanting to see more data is really, is really important in this space. And given those high costs, I wanted to have the opportunity to look a little bit at what the costs of using robotics in spine looks like. So, these systems are between, $500,000 to $1 million each. And so the value proposition for these tools should really be sound. In a paper by Richard Menger, who's from LSU, they took a deep dive at this, and this was published fairly recently. Since again, this is new data and a new area to look at. They found the potential for $600,000 of savings at a facility with about a 557 elective cases over a 1-year time frame, an academic center, which on the surface that sounds great, but if you dig into the details a little bit and see what they're, how they came to that, it's kind of an interesting story. So first, 3.4 minutes of time is saved per procedure, and anyone that spent any time in the operating room, we know it's virtually impossible to capture 3.4 minutes of savings. A lot of times 10 minutes is 15 minutes isn't enough to capture. And so wondering how that's going to translate into real dollar savings for the hospital. And then next, for about the 9 revisions that are avoided, this is great. Avoiding revision surgery is a huge cost to the system, a huge pain literally for the patients, and something that is an area where that could translate into real savings. And it's been said that the future cost benefits of robotic surgery, this might be the area where the research can demonstrate that the cost savings and the value proposition is really key. And then next here, looking at infection rates. So infection rates, and this is compared to open procedures. We know that infection rates in open procedures are higher than in minimally invasive procedures. So what is due to the robotics versus the just being an MIS procedure? And then lastly, the length of stay, they reduced 140 ward days across the group, which resulted again in a pretty substantial contribution to the benefit. But length of stay with MIS procedures as well is known to be lower than without robotics. And so again, what's the comparison? So what's really needed is really a 3-arm study that compares an open procedures to MIS procedures to robotics procedures to see what the real difference is between those groups. That being said, though, the great, really the sheer size of the orthopedic market and the potential for share gain is not shying anyone away from the additional development in this space. Companies are definitely still working on improvements and ways to address the use of robotics and computer-assisted tools in spine and orthopedics. And the near 13% growth rate, is really attracting all players, especially given the opportunity for a wide range of potential spinal indication expansion to be used in other areas of the spine. Now, so given the growth and potential, what are the real benefits of buying the robot? Where we are today, feeling okay about them, but still knowing the costs are there. And the question is it really marketing? Here's 2 articles or snapshots from Beth Israel and Boston Children's, local to us here, where they're using the robots as a way to market to patients to say, come see us, we are the best in the space. And I know Dr. Shah, I'm sure, has a perspective on this as well, but then a patient might come in and say, I want to use the robot on me, but after reviewing the patient in their particular situation, that's not the best option. You want to do something else, but still the patient came to you because of the robotics. And anecdotally, I've heard that companies are telling surgeons to use a new robot, use it for a percentage of your procedures, and will help you fund the marketing of this device to get the word out. So there are definitely interesting dynamics that are associated here. So with all of that, what's next? What are some of the new things that companies are looking for on top of the computer-aided navigation and image guidance and the robotics options? The first one is combining digital tools, which is not necessarily the same as robotics, but using digital tools across the spectrum of the patient. There's an example by J&J, this VELYS digital surgery system, where they're doing everything from preoperative planning through postoperative care. And larger companies with a wide range of resources are really probably going to be the ones that are going to lead the pack with this kind of approach. And patients are interested in having more of these tools available to And then lastly, the use of augmented reality in the operating room is something that as well is on the is being developed. I came across this technology researching this space a few years ago, and they overlay augmented reality tools over the patient. And the idea is that you would be able to, check your reference images, check the trajectory through the overlay, and essentially operate onto the bony anatomy and some of the soft tissue anatomy, looking through this device, so you know where you are. So, that's pretty cool. I was really amazed when I saw this technology and how they're advancing this forward. But still the lagging latency, jittering and other issues with the augmented reality tools that are in place today still need to be overcome for this to be widely used in OR. But you can see how this could be a beneficial option for the future. So, at the end of the day, we've seen that MIS and spine has really been beneficial, that the use of image guidance tools and computer-aided navigation is really, really helpful in the operating room. And while robotics, we're seeing some early benefits and some hospital systems that are using it to great patient benefit as well. So the cost and benefit ratio and the value proposition still needs to be fleshed out some more before we feel that the robotics can have a really wider use and growth into the future. So thank you.
All right, Ilsa. Hey, thank you. Thank you very much. Again, fantastic, really exciting technologies in the space. I know we've seen a lot of robotic acquisitions in orthospine, and it's interesting to see where those are going, and also look at the fact that there's a long way to go in really evolving the technology, as is the case across all of these systems. So fantastic, and thank you. And I think I'll go ahead and share my screen. I'll be presenting the final content for this evening. If there are any questions for ILSA, do post those. We've got a pretty good running list at the moment, and we'll try to get to as many of those as we can. So moving to the final presentation this evening, and before we open it up to Q&A, I'd like to cover one more area of technology development that is evolving quickly in the MIS space, perhaps a little bit different than what we've seen tonight, and equating to a lot of what's happening in diagnostics, wearables, and telemedicine, and that's the leveraging of consumer-based technologies to develop novel systems and capabilities for the MIS operating room. So with much of the industry focus on robotics, AI, VR, and appropriately so, we're seeing amazing things tonight, there is an underlying wave of new tech designed through the lens of consumer-based products that is poised to impact the MIS environment, impacting how surgeons interact with technology, perhaps and likely altering the points of care. So we look at minimally invasive surgery, it plays such a critical role within hospital systems that are facing many challenges within a very dynamic environment. If we look at referencing the Institute for Healthcare Improvement's quadruple aim, attempts to address these challenges focus on improving the health of a broad and very diverse group of populations, enhancing the patient experience, reducing the cost of care, and importantly, improving the provider experience. And this, I guess in lay terms, suggests making sure that surgeons, per our conversation tonight, are actually enjoying their work. And these challenges are also being addressed in a market in which we're also seeing a rapid change in where MIS procedures are performed. For years now, there's been a shift of MIS procedures to outpatient ambulatory care settings. And this trend is likely to be pushed even more so by the environment that we're experiencing today through the pandemic. More and more routine procedures are being moved away from the primary hospital setting and into these outpatient centers. And taking this even a bit further, and I'll highlight a few of these technologies in a moment, there are technologies entering the MIS market that are moving diagnostic procedures and even some treatments from the OR into the clinic. We're seeing this occur more so in orthopedics at the moment, but other specialties are certainly not far behind. So given these trends and market dynamics, we're starting to see some new approaches by innovators in the space in the search of novel solutions for the unique needs of this and the rapidly changing environment. Well, not a complete list. Some of the major themes that arise are kind of shown here. Less invasive procedures, this constant push for less invasive approaches to these surgical procedures, greater efficiency, faster turnaround times, less expensive and cumbersome, more mobile equipment, reduced time and money for re-sterilization, maintenance, repair for these capital equipment devices, reduced learning curve for MIS surgeons and of course surgical teams, and of course the overall lowering the cost of care. In working through that list, it's not much of a leap to see that leveraging innovative solutions from the consumer product market can provide a solid foundation for considering a lot of these new approaches. So when we look at consumer-based technologies, we think about in our homes and when we carry these devices around ourselves, smaller footprint, more mobile options for the operating room, movement from physical capital to digital solutions, transitions from reprocessed to disposable electronic devices, increased access to training and telementoring, bespoke devices designed specifically for surgical specialties, but also for the individual surgeon. It's certainly possible with these kind of technologies, and movement from capital to operational expenditures, which impacts the administrative areas as well. And of course, capabilities that are inherent to these devices, things like connectivity as well. And of course, we've been seeing for a while now, really the passive introduction of consumer tech in the OR. So Apple devices, Google, Samsung, these devices that we carry around with us are of course making the transition into the OR. And we've seen a lot of this. Google Glass, which had some time, it's fallen out a little bit of favor, but the technology is there. You see this example of a cystoscope with a iPad or iPhone attached to it, as well as surgeons using iPads and iPhones on a daily basis to view images, view scans, look at data, and incorporate this technology. So you really see this passive use emerging into the MIS OR. But that's starting to change. Development from the perspective of utilizing some of the underlying technology to develop unique technologies that are specifically for surgery. And a lot of those, at least at the start, are focused on the visualization space. So using low-cost image sensors and imaging platforms to build new and really interesting visualization systems for the MIS space. Now, as I mentioned before and previously, some of these new systems are allowing diagnostic procedures to be performed in the clinic for the first time. So no need to schedule OR time, staffing to diagnose and establish a treatment path. You can do these diagnostic procedures, and we're seeing arthroscopy and some other procedures in orthopedics done right in the clinic and being done so very safely, saving cameras and technologies to build laparoscopic visualization systems for the OR. In NuView Surgical, we're working on a similar technology. We're developing a novel solution for laparoscopic and thoracoscopic procedures by streamlining and combining the visualization and access equipment necessary for MIS, incorporating high-end 4K sensors, lighting systems and image processing technology, from established consumer technologies, develop simplified, mobile, user-friendly, and much lower cost visualization and access systems for MIS. With the aim to match the needs of the evolving market that I shared before by improving surgical outcomes and the efficiency of care, with an early focus on visualization, as we've seen, these simplified yet high-tech solutions are also bringing to market new approaches that address the patient experience, user training. We're while also lowering the overall cost of care. With this in mind, we certainly expect this aspect of technology development to rapidly evolve for the years to come in parallel with a lot of the exciting stuff that's happening in robotics and AR and VR and the like. When considering the current market trends, it's robotics, VR, everything that's happening, it's certainly going to change MIS for the better, but there's no doubt that more simplified, mobile, lower cost solutions that are still very high-tech solutions are likely to play a major role in the future of surgery as well. This may be even more true in lower resourced environments. While MIS has grown tremendously and has become the standard of care in many places, there are still many locations for which open surgery is still the norm. MIS equipment is hard to come by, training opportunities are limited, and high-tech MIS equipment is unaffordable, let alone difficult to service and maintain. So at least some of our focus in the MedTech industry should entertain new thinking around MIS technology and how technology platforms can solve really what is a disparity of care around the world. So just in some closing thoughts, some food for thought on how we might, as a MedTech community, think about the world of consumer technology and how we can impact further development efforts in MIS. Just by throwing away what the current OR looks like and rethinking the classic MIS OR environment, from towers to booms and all this high-end capital equipment, how might that environment change? Certainly a focus on simplicity, ease of use, limiting and reducing the learning curve for current as new surgeons alike, as well as for surgical teams. Adding new expertise to the MedTech space in consumer electronics and software design, adding talent in these areas, and of course, direct collaboration with consumer electronics firms. And I guess that ties closely to strategic and supply chain connections with chip suppliers. I know for a while with companies working in this space, it's been difficult to work with chip suppliers and bring sensors and image sensors and processor boards to these MedTech development efforts, but we are So with that, go ahead and wrap up today's presentations, but go ahead and move over to the Q&A session. I did see before I started about 30 questions had been compiled. So we'll go ahead and get back to the panel and we'll dive into some of the questions that you guys have. So thanks very much for your attention to this point, and let's open it up to some Q&A. All right, I think we see everyone and everyone's off mute. Let's just dive in. We've got, checking the time here, just about 5-10 minutes for a few questions. So we won't be able to get to all of them tonight, but we'll certainly go ahead and get started. So Dr. SHAH, starting with you, and I think perhaps Tom, you could dive in here as well. How is one considering the variability of surgery? Surgery is done very different from surgeon to surgeon, let alone hospital to hospital and around the world. How do you consider that variability when designing and trying to measure surgery, trying to bring AI, try to develop robots that could one day perform surgery? Do we need to reduce that variability amongst surgeons before we measure it and really move into these new technologies? What are your thoughts on some of that?
Yeah, I mean, when I think about variability between surgeons, I think about how do we measure it now? It's by outcomes, right? Like if you take, for example, laparoscopic cholecystectomies or gallbladders, and these are things that when you think about new technologies, this is a place where, I think the gallbladder is probably the #1 general surgery procedure that's being done in the world. And why is it with all the technology in 2020 that there are still surgeons that will, cut the common bile duct, right? Which is a major complication, which can lead to death for some patients. So when I think about variability, I think about outcomes of specific surgeons. So how do we can measure variability by their outcomes in terms of complications, and we can look at all sorts of complications. We can look at operative time, we can look at the cost, and then we can kind of go back and say, well, how do we reduce, like people dying from a laparoscopic gallbladder because their common bile duct was cut. This is how I think about variability. How do we reduce that?
Yeah.
Yeah, and if I can just kind of add to that too, Dr. Shah. So I think we have to embrace the variability. We have to recognize that it exists. It's different how cases are performed here in the U.S. and across the world. Different hardware, different systems, different patient population, demographic. So on the AI side of things, I think it means that we need to collect more data. We need broader data sets that encompass all of the demographics and all the corner cases. And that's why it's so important to start early and really work with our surgical partners here to decide what is best. I think, quite honestly, I think that starts in calling out the phases of surgery, quantifying the surgery, quantifying the phases, and then working toward bringing to that mean and identifying the trends that lead to the ultimate best outcome. But it's going to take a lot of data and a lot of effort to get there.
Right. I think one of the other challenges, which I don't know if people realize, is that surgeons don't like to be evaluated.
Mm-hmm.
And I think it makes it tricky because even when we think about even telesurgery, there's been programs I've been involved in and just like doing a common technique in another surgeon, like a master surgeon, looking in. Nobody really signs up for that. No one wants to be judged on how they do a procedure. And I think that's where the tricky part comes in, is because you're talking about data to say, if you can look at like 500 procedures of one type and say, where did it go wrong? That surgeon doesn't want to be evaluated to say this is where the mistake was made. And so I think that sort of data, which is, I agree, very important if you want to do AI and machine learning, the surgeons have to be on board with that.
Right, agreed. Nope.
You're on mute, Bryce.
Mm-hmm.
You're on. He's working on it.
Okay. Maybe what I could do is, in the meantime, I can comment from a spine perspective where, there's each screw has multiple degrees of variation. And so then the question is, does the robot actually help avoid that variation by surgeon? Because you will have a very direct record of and plan for where each screw is going to go, and therefore might actually, with the data that I showed, increasing accuracy of screw placement, maybe even help those surgeons that need a little bit more training or a little bit more guidance on where those screws should go, either, if they're earlier in their career or, take the opportunity to track that accuracy over time. And that might make a difference, at the end for better outcomes for patients.
Definitely.
Great.
My Bryce is back.
I'm back. Mute is off, so I could talk again. I wasn't saying, it was just a great discussion. I mean, why have me get in the way? So just a few more questions. I know we've reached the 7:30 hour. Again, a lot about robotics, because we presented that tonight. What's administration? I guess surgeons, but more administration thinking is Intuitive has really been out there. We've seen a lot of the robots in ortho spine, but there's about to be a wave of new robots coming onto the market, whether they be $500,000, $1 million price points per robot. What's administration thinking about what this influx of robots is going to look like as they start to hit the market over the next year or two?
I can tell you what we're hearing. It's from the large centers. There's a reluctance to purchase very specialized systems. That this is a ENT system, this is a general surgery system, this is an orthopedic system, and have the number of a vast capital outlay in these types of kind of closed off systems, if you will, especially if they don't connect to each other. That being said, right now there's really no general purpose surgical systems out there, and they all do cost a lot of money. So I think there's definitely an economic case that needs to be made, and an outcome case that needs to be made, and they're becoming more and more prevalent. the publications. That being said, we need them faster. We need them, with stronger patient populations and bigger sample size to really drive reimbursement. Right now, robot procedures are being, as far as I know, being reimbursed the same as minimally invasive procedures, and that's going to reduce how many systems can be purchased and used. So some work to be done.
Yeah, and the research that I've been involved in, where we've talked to value analysis committees and asked them about the adoption of new technologies, they're continuing to be stricter and stricter with the value proposition and understanding what benefit are the patients going to get over what they have today and what they currently are able to do. And I think to your point about having those, the research done to demonstrate that you are actually going to have a benefit will be the tipping point in swinging to adoption of more of these technologies, definitely on the orthopedic side, and I assume on the soft tissue side as well. And one area I didn't mention in the interest of time, but Intuitive's Da Vinci has been used for an ALIF procedure. It's an anterior lumbar interbody fusion procedure, and they're using it, I think, sort of like more like an access surgeon rather than doing the actual spine surgery itself. But there is the opportunity there for them to, they're taking that opportunity. The Intuitive started to look at what other areas can they branch into, because if you can use that procedure across the robot across multiple procedures, that's where you get that additional value, checked off for each procedure it's being used.
I think in terms of academic hospitals, I think there's two things that they think about that's finance agnostic. One is it's true, when patients come to see you and they come to see me and I talk about fixing their hernia robotically, laparoscopically, or open, they really have no idea what the differences are. And I could talk anybody into doing robotic, but they just, in their mind, it's like some robot that's doing the surgery and I have nothing to do with it, right? They really don't. You have to take that time. But I think why hospitals, find it attractive, because just for that reason, like patients like, oh, Tufts Medical Center is doing this robotically, like I'm going to go. And it does. It brings in more patients, whether you use a robot or not. It's one thing, but it attracts more patients. And especially in Boston, where it's so tough, where it's such a dense academic, it's like the mecca of medicine, and we're all like, fighting for like literally the same patients. Like, how do we stand out from the other hospitals? That's one. Two is academically, we know that we have to teach the next generation of surgeons, right? So I struggle with this, is that I'm learning this as an attending, and I've been in practice now for 13 years, but my residents, when they get out into the real world and wherever they go, I want them to have that skill set, right? Because I don't want them to say, I didn't learn. Like, it would be shame on us that our residents didn't have access to a robot and have learned something on the robot, right? And I think that's something that at least academic centers are looking into, thinking about, one of our missions is research and education. And I think it's doing an injustice to all surgeons of all disciplines if we are not giving them access to a robot and teaching them.
Oh, Bryce, you're gone again. Sorry.
Can't hear you.
It's about specific technologies.
Yeah.
Can you guys hear me okay?
Yep.
Now you're back.
Okay. Yeah, sorry about that. I think a lot of people are streaming Netflix.
Yeah.
Oh, no.
Now he's frozen, I think.
Yeah. Well, we can grab another question from the list here.
Wrap it up.
There was something on haptics. I think that, oh, he's
Yeah.
back.
Great.
I still can't hear him. Tom, or
Yeah,
let's
yeah,
get
I mean,
out. Yeah.
yeah. So I think that haptics question is interesting. Haptics is one of those things that's been talked about for, I don't know, 12 years that I've been doing this, as to, when is it coming? So, actually, I'd love to hear your thoughts, Dr. Shah, as to, what does it enable? When should we see it? And how much do you need it?
Really need it. I mean, I think the things that I struggled from going from laparoscopic to robotic, like I I see myself as a very advanced laparoscopic surgeon. Like I can do pretty much anything laparoscopic. And the reason why I decided to do some robotic training is because there's definitely in some procedures such as advanced hernia repairs that the robot really, with dexterity and being able to suture, really adds another tool for me to kind of treat the patients better. And one of the things I struggled with is the fact that there's, really no sort of feedback, right? So really having to train myself to say, okay, look at the tissue, it's blanching, you're holding this way too tight, or like suturing and realizing that I'm putting a lot of pressure and the suture just pulls out. So I think haptics is huge. And I think especially when I talked about those surgeons that go from open to robotic is because they can really mimic whatever they did open robotically. But the biggest, I think, skill set that they need to teach themselves is that ability to look at other cues of figuring out, the strength.
Yeah, right.
Great. Hopefully, can you guys hear me okay now? So for a moment. All right. Again, the Netflix streaming is killing me, but we're gonna have to wrap it up. I think a great discussion. I know many questions remained unanswered. A lot of questions on different technologies from wireless to IR, a variety of different things. But I appreciate everyone's attention tonight and time, and great set of presentations that we had. Appreciate everyone's effort in going into this, and hopefully the audience really got some great content on the advances of MIS surgery and where it's headed in the future. So I'll turn it back over to Jeff, our champion tonight. And thanks again, everyone, for participating. A great event this evening. And Jeff, we'll put it over to you for the closing remarks.
Great. Thank you very much. I don't know about you guys, but there's a little bit of this going on. I just want to say thank you to everybody who participated in this online forum tonight. MDG's not done this before, but we are really known for addressing innovation in a very strong way. So once again, thank you to the entire team, our operations folks, Bill Munger, Bill Dennison, to all of our panelists, to our attendees who provided great questions. Sure wish we had another couple of hours for that. And especially to BRYCE KLONZ, bringing this great team together and driving this group through a wonderful presentation. I was hoping to have the poll results from the areas of industry that all the attendees have been from, but I haven't seen that yet on my screen. So we'll chalk that one up to one small tech glitch, but I can bet you that every single one of those boxes was checked off by someone. So that's great. And also, there it is. And guess what? I was correct. There is someone, many, from every single group. Who is our largest constituency tonight? Engineering and science, design and development and manufacturing, consulting and strategy, followed on by marketing and sales, and entrepreneurial and finance, a very large contingent. That's wonderful to see. So thank you everybody for coming. I will say tonight, if I were to have any takeaways, I would probably be incorrect, but I would say we're not getting rid of the surgeon anytime soon. It's great news. We have such great talent everywhere in the world for surgery, and laparoscopy continues to grow. Thank you very much tonight. Everybody have a good evening. And hey, you're already home, so you're going to be traveling safe. Thank you very much.